Right, Mustafa Khan. Dr. Samu here. So, as you said, there's a learning curve for the TRP. So, when you compare it with this for the laser, what do you think? Which one is harder or is exposure?
Yeah. Maybe we can mute the other participants so that you can hear me better. So, learning curve for TRP, as you know, normally when the trainees are doing TRP, we will allow them to do the median lobe to start with. We will allow them to do maybe one side of the prostate, and then the boss or the consultant will jump in and do the rest of the thing. The same thing with whole beam enucleation also. Maybe do 3 or 4 enucleation of the median lobe alone, and then push into the bladder, get that feel of enucleation, and then ask your mentor or the consultant to do the lateral lobes, and then slowly start doing the one lobe and leave the other lobe for the consultant to do. Lot of videos available in the YouTube, like the video which I showed you. Observe the video, get conceptualization of the anatomy, and then after maybe like another 4 or 5 patients, you can start doing the Moss relation. Moss relation is a very important procedure, because during the Moss relation we should have a good irrigation to make sure that the bladder is nicely filled up, so that the Moss relation probe should not come close to the bladder mucosa. I will say for an experienced person like your team, maybe 20 patients is the learning curve. Once you have done a good 20 patients, prostate measuring 60 to 100 cc, then there is not much learning curve. And Javad has just sent me a very beautiful resection of TRP specimen, and when it's a good resection, so nice to see. We can see the experience there, but at the same time, it's a very very tiresome procedure. The same gland, if you are able to do by enucleation, you will be able to finish maybe less time, and the satisfaction of going up to the capsule is the best. That's why in the Western conferences they say enucleation is enucleation. Enucleation is the king. That's a usual term we use.
One, I'll add to this question. You said MRI or TRUS. Are they mandatory before doing this procedure? Because
Not necessarily, but in the initial stage, I will say at least transrectal ultrasound to know the like a volume of the prostate, because I can see your team, the trainees are sitting in the back. So if you have to train a trainee, you know how much the gland size is. And if the gland is bigger, it's better to have a senior consultant in place. If the gland is like 150 200 cc, it's better to leave it for something like a workshop, so that we can do it in a workshop when we have the faculty visiting from other countries. So that's why a good measurement is very important, because by using a transrectal, I mean digital rectal examination, it's very difficult to say about anything more than 80 cc. Anything more than 80 100 cc, the gland looks big. We don't know whether it's 200 or 300, nothing we know. We don't want to go without knowing the proper volume. MRI is needed only if the PSA is increased. Otherwise, there is no need for MRI.
there are a couple of questions in the chat. You can
Yeah.
Yes, very nice discussion. But Ananda, it's very difficult to compare the Western world with the our setup.
Yeah.
And we are working in public sector, and yes, MRI, yes, all these things, laser are important. But in our city where I am working, where we are working, we are not having laser everywhere. In public sector in our country, at one moment, as I told you, 15 years before, we were having Orega and we were doing OLED. But now, unfortunately, not. But still, we are, thinking and we are doing it TUR. As I send you a picture during presentation, it was 150 and I was quite comfortable to do it TUR. And it was nicely done. A month ago, patient is doing well. So yes, MRI and all these things are important, but here is not routine done. Well, a resident must know that, but practically it's difficult.
Yeah, I agree. At the same time, the thing is like we don't need a very high power laser every time. It can be done even with 30 to 50 cc, 50 watts low power laser also. It is not as convenient like a good like a 120 watt Moses, the latest laser machine, but it can be done with a low power laser also. But you can see that when we are doing with high power machine, the hemostasis happens simultaneously, while with low power machine we need to be very mindful with the hemostasis. And so if you have a low power machine for stones, we can easily use that for enucleation.
Hello, this is Imran from Department of Urology. I have one question. Considering the economical status of the developing countries, what is your recommendation of doing surgery in gland of around 60 to 80, whether it's QR or volume? Because cost is definitely an issue.
Yeah. In TRP, the cost is much less because we are just using the loop or the rolly ball again and again after autoclaving. So there is not much disposable cost. And also, if you are doing normal monopolar TRP, maybe the glycine is cheaper compared to the bipolar TRP where we are using the normal saline. The cost is always there, but we all agree, at least for the stone purpose, the stone in ureteroscopy is better than using the long lithoclast. The outcome is better with the stones, there is no doubt in it. So if you have a laser machine for the stone, there is nothing wrong in offering it for the patients for the prostate. Maybe that initial offering of 60 to 80 cc or up to 100 cc is only for the training reason. Once a person is nicely trained, we can just reserve the holmium enucleation only for glands more than 100 cc, and less than 100 cc we can still do TRP. So that is more economical model, and also will keep the training going ahead.
Sir, I'm Dr. Bulkayu.
Yes, please.
I'm chief residency here. So what are your laser setting for the enucleation?
Yeah, as I showed that the laser setting is 1.2 and 60 hertz. So even though it's a 120 watt laser, we are using only like 72 hertz. So it's not a very high power usage to start with. We don't need high power laser. It's more of like convenience actually.
Ananda, I'm Vakar from Hyderabad Urology. When we are talking about the learning curve in doing the HOLIP laser enucleation, so what is, I think when you are using the thulium laser, which is quite friendly because it has cutting as well as the vaporization. So do you have any experience in comparison with the HOLIP or using the thulium energy or the bipolar?
Yeah.
What is the which one is more friendly if you are able to buy a laser machine, whether we buy the holmium YAG laser or thulium YAG laser or TFL? What is your suggestion regarding it?
Yeah. Uh, TFL is slightly kind of a different thulium. Okay. So if you are buying something new, TFL is not a bad choice because TFL seems to be much more good in the dusting of stones also. So I will be very mindful if you are buying something new, always think of what is your usage for stones and what is your usage for prostate so that the investment is gone correctly. TFL has proved that it's very good for dusting and very good for large stones and also for prostate. But if you are not using TFL, just the normal thulium is not very good hemostatic compared to holmium. Holmium is very dependable, while thulium, when you see the videos which I've shown you, the holmium creates the nice plane, it's nicely blanched out, whitish one. While thulium, it creates the charringness, the blackishness in the area. So after full enucleation, you can see the whole prostatic cavity is bit charred, and that charring will take time to heal, and it will cause a kind of a burning sensation and stress incontinence for the patient. So if you are going for a new machine, if you have a good stone volume load, TFL is good, nothing wrong in it, but I will say holmium is equally good. But the normal thulium laser, I won't say it's a brilliant one for the enucleation.
May I- Yes, thank you very much, Ananta. And there are a few questions I think in the chat. Please If you happy to answer these, please.
Yeah, sure. So the one question we saw in the fluid, can we do whole meme enucleation while doing lap TVP? So is a lap TVP means like a laparoscopic enucleation of the prostate. That's what they mean. What is lap TVP? I don't know.
Can you unmute this, Dr. Shahzad? He can directly answer this question.
We are unmuting Dr. Shahzad. He will explain himself.
Okay, please.
Better.
Because this enucleation can be done by robotically. People have done simple prostate enucleation by robotically, like a Frey's method, transvesical, and stones can be removed at the same time. I just want to know what he means by TVP.
Dr. Nanda, yes, you got it rightly. Lab TVP means enucleation of prostate during laparoscopy.
Yeah, so it's like indirectly, instead of robotic simple prostatectomy, you want to do laparoscopic simple prostatectomy. If something is able to do by robotic, obviously it can be done by laparoscope also. In the Western world, since the laparoscope has almost replaced with robotic, and this simple prostatectomy has come quite recently by robotic method. Everything, all the publications were on robotic simple prostatectomy, and commonest is, as I said, is a transvesical Frey's method. The open transvesical Frey's method is just replicated into robotic assisted transvesical Frey's
Yes,
method.
we are doing that. We are doing that. We
Yeah.
are doing that by robotic. I was just asking, can we use this method of enucleation by during our robotic prostatectomy?
Yeah, we can do the same thing by laparoscope. Yeah, of course we can do that. Yeah.
And I think if I can make it easy for Dr. Shahzad, he want to do something anti-gradely rather than retrogradely.
The other question from my side is, Dr. Ananda, do we need to stop anticoagulation drugs before this procedure?
Yes, at least in the learning curve, maybe in the first 20 patients, stop all the anticoagulant drugs, including aspirin, nothing wrong in it. But in long run, taking 75 or 150 milligram aspirin and medications like clopidogrel are okay. We have done patients with clopidogrel and aspirin, but the newer drugs like rivaroxaban, epaxaban, they needs to be stopped for at least 2 days, and warfarin has to be stopped for at least 5 days till the INR comes. INR, best INR as we know is 1.5, less than 1.5, but up to INR 2, 2.1 is doable. Just we need to be a bit more careful, make sure that the hemostasis is done well.
My last question is, Dr. Ananda, can we convert the procedure if you are not feel comfortable going
Yeah.
with this thing
Yeah.
at the same time, or we do the procedure later on?
No, anytime. Say, for example, you are enucleating, you are doing it at any time. If you are not comfortable, just change the working element, make a TURP, and start resecting it. So, the areas where there is absence of Moss relator, as I showed in the video, you can do a good resection, release the anterior part, release the posterior part, do everything so that the gland will be hold only at 6 o'clock in the bladder neck. And then if you don't have Moss relator, because again it's an investment, just take the TURP and then do TURP resection. Since there is no bleeding into the gland, you can resect everything and remove everything as TURP chips. That's another easiest way, and you will be saving money in buying the Moss later, at least in the initial stage.
Thank you very much, Dr. Anand. Thank you.
The one word for take-home message by Dr. Shahzad question, and the urologist must know how to do the TURP before having enucleation.
100%. Yeah, TURP
Thank
is
you
the
very much.
yeah.
Thank you very much once again, Ananda. Nice to see you, and hope we'll have you soon. Excellent lecture. Thank you very much.
Thank you very much. All the best, and happy to help in setting up the service and do some workshops in the next visit. And let's do the best for the patient. Thank you very much.
Thank you once again.
Bye.